Okay. Hi, I'm delighted to be in Bilbao today with all of you. I'd like to thank Spela and the organizing committee for inviting me. My name is Nina Žakelj. I'm a neurology resident from Ljubljana, and I've been a part of the CTNNB1 research team for about 4 years now. Today, I will present the results of our genotype-phenotype correlation study. It's just about to be published in a journal, so it's not published yet. You're welcome to take pictures, but please don't share them online or in a public space until we get the final publication. So since this is the first scientific talk of the day, I thought we could start with the basics. So we know that genes encode proteins, and healthy proteins then have different functions in the human body. And in the CTNNB1 syndrome, the gene of interest is the CTNNB1 gene that encodes a beta-catenin protein. This protein has different functions, from cell adhesion to cooperating in the Wnt signaling pathway, which has a lot of different functions. For example, in the embryonic development phase, it is responsible for tissue and organ development. And then in adult organs, it deals with tissue homeostasis, cell renewal, cell regeneration, and cell differentiation. So you may ask yourself, what happens with the protein when there's a genetic mutation? And this is where it gets a little bit complicated. So based on the mutation's effect on the protein's expression, we have different variants, which are roughly divided into loss of function and gain of function groups. So in loss of function variants, could be either a complete loss of protein formation, or there could be a reduction in protein's function. And to make it a bit more complicated, there's a third option, which is called the dominant negative variant, in which the protein that gets formed is abnormal. It's called a truncated protein, and it basically inhibits the function of the healthy copy of the protein. And in the gain of function variants, there can either be an increase in protein's function, or the protein can get a completely new function, which may intuitively sound like a good thing, but in most cases, it's not. So in CTNNB1 syndrome, we all know that it's a rare neurodevelopmental disorder, and it's caused by an autosomal dominant de novo mutation in the CTNNB1 gene. We all know that it's rare, that's why we're here, but it may actually not be as rare as we think. This is a study that was recently published. They were testing basically genetic backgrounds in children with cerebral palsy, and they found out that a third of those children have some sort of a genetic mutation, and CTNNB1 was the top causative gene in that study. So this syndrome is likely underdiagnosed due to insufficient characterization, and to kind of help and add to the science, we decided to embark on the journey of our genotype-phenotype correlation study. So this study was performed between May of 2021 and November of 2022. Everybody with a diagnosed and genetically proven pathogenic or likely pathogenic mutation in the CTNNB1 gene was welcome to be a part of this study, regardless of their age, gender, nationality, or their spoken language. So the participants were invited to meet me online, where I took them through a detailed medical questionnaire containing over 500 different questions. In the interest of time, I won't be listing them all. There were a lot of standardized questionnaires as well, and I'll be covering the most important ones during this talk. And what started as a relatively small effort then quickly caught on fire. On top of the amazing research team in Ljubljana, we were joined by some amazing doctors and researchers from all around the world. Shivang in India, then Leszek and Andrea in Australia, Professor Chen from Hong Kong, and Professor Sanders from Oxford. And what I'll be presenting today is truly a collaborative effort of all of these people. So I interviewed 127 families. 2 participants were later excluded due to insufficient or scarce genetic reports. The mean age of the participants was 70 months, and the range was between 7 months and 20 years of age. We had quite a good representation between genders and a good representation all around the globe. The participants were residents of 20 different countries. So 73% of the reported variants were pathogenic, 27% were lightly pathogenic. What's interesting is that almost a half of the parents got tested as well, and all of their children had a de novo mutation, so none of them were inherited. Most of the mutations were either frame shift, nonsense, splice, or whole gene deletions, and in these variants, they result in a premature termination codon, which leads to nonsense-mediated decay, and in these mutations, we expect a loss of function mechanism. 4 patients had a missense variant, which is a bit more tricky, and I'll talk about it as my presentation goes on. So out of the 125 genetic reports that we had, 43 were additionally tested in Professor Chen's laboratory in Hong Kong. So 43 mutant beta-catenin cell constructs were additionally examined to determine what variant this mutation causes. So most of the variants were loss of function variants, which was, as I said before, expected, but we found one mutation that causes a gain of function, and that's the one that you can see with the highest peak. Specifically, this was the G575R mutation. The loss of function variants were then additionally tested, and we found 4 mutations that have a dominant negative effect. So, like I've said before, in the dominant negative effect, the truncated protein actually inhibits the healthy one, which can theoretically lead to worse outcomes. And these 4 mutations were the ones that had the dominant negative effect, and 11 children had these specific mutations. So regarding clinical phenotypes, there were basically no important differences in prenatal and perinatal characteristics in terms of mean gestational age, mean birth weight, or birth complications, but we did find higher reports of intrauterine growth restriction, microcephaly at birth, and feeding issues after birth. We also established dysmorphic features. Most commonly reported were a broad nasal tip, then thin alenasi, a long philtrum, thin upper lip, big ears, and also thin hair. And I always like to show this slide because I think it really shows that regardless of the kid's age or gender or nationality, these dysmorphic features are present in almost all of the children. Regarding neurological signs, most often reported were muscle weakness, central hypotonia, peripheral hypertonia, also syndromic atypical hyperexplexia, which is a complicated term that basically means an exaggerated startle reflex. And there were also high reports of dystonia, spasticity, and stereotypical movements. So 60% of the children had EEGs performed before joining our study, and only 8% of the EEGs were abnormal. And most of the patients had an MRI, brain MRI performed as well, and it was abnormal in 28% of the cases, mostly due to white matter abnormalities. So we assessed the children functionally as well using different standardized scales. So the first one was the Viking speech scale. Most children corresponded to level number 3. This describes a child who needs a lot of help to communicate in unfamiliar environments. On the functional classification system, they corresponded to level number 4, which again describes a child who's able to communicate at home, but maybe people that don't know them have a hard time understanding them. In the gross motor function classification system, most of the children corresponded to level number 2. This describes a child, in case of older children, who are able to walk a little bit unassisted, but mostly require some sort of a support for longer distances. And in younger children, it describes a child who's able to sit with little minimal support. In the visual function classification system, most children were level 3, which means that they can use visual function, but need some adaptations, for example, glasses. And regarding visual function, parents reported strabismus in 80% of the cases, also some refractive errors, and fever was present in 7% of the children. And based on our findings, most of the children were able to eat and drink by themselves. That's the eating and drinking ability classification system score, or level 1. We also found significant delay in reaching milestones. So 92% of participants older than 2 years were only able to walk with assistance, and 73% used some sort of a wheeled mobility in their daily life. Regarding neurodevelopment, half of the children had at least mild intellectual disability, and then additionally, a quarter of the children had moderate to severe intellectual disability, and the quarter had basically normal intellectual functioning or borderline intellectual capabilities. Parents also reported increased rates of withdrawn behavior, symptoms of anxiety and depression, thought problems, and attention problems, and almost half of the children scored above the cutoff values for autism spectrum disorder. Regarding genotype-phenotype, we tested, or I should say we compared 3 different domains: motor development, neurodevelopment, and functional status. First, we compared these 3 parameters in children with loss of function dominant negative variants and loss of function non-dominant negative variants, and we found no significant differences in their development, adaptive functioning, psychopathology, or functional assessments. Then we tested loss of function dominant negative types versus loss of function not dominant negative, all loss of function, and loss of function presumed variants. And again, we found no statistically significant differences between these children. Next, we test the same 3 parameters between different variant types, so between missense, frame shift, nonsense, splice, and whole gene deletion variants. And what we found is that patients with missense mutations started to walk earlier. They had better conceptual skills, better social skills, better communication skills, and less feeding difficulties, as well as better motor abilities. However, we found no significant difference in psychopathology between the groups. Lastly, we compared the same 3 parameters between patients with confirmed gain of function mutations, confirmed loss of function mutations, and all other variants. And since there was a small number of gain of function mutations, only 2 with that missense mutation that I mentioned previously, the correlation was explored with descriptive means, and we found no significant difference in motor development or functional status, but they did have better adaptive skills. As you can see on this graph, the green line represents confirmed gain of function variants, the red line confirmed loss of function variants, and the black line represents all of the other variants. So the key points of my talk are: CTNNB1 syndrome has a clear and distinctive phenotype, and patients fitting said phenotype should be systematically tested for a CTNNB1 mutation to ensure a quick diagnosis. The mutations of the CTNNB1 gene can result in loss of function dominant negative, or gain of function variants. And while there are no clear genotype-phenotype correlation between these 3 variants, it is probable that patients with loss of function negative dominant variants and gain of function variants won't be included in the first phase of the clinical trials because these variants are just a bit too unpredictable. In comparing different mutation variant types, there was a favorable genotype-phenotype correlation in regards to patients with missense mutation who tend to be doing better. And also the number of missense mutations was quite low in our study, so there were only 4 patients. And we can explain that by maybe children with a missense mutation doing better and are thus less likely to be included in studies. So this brings me to my final point. Bigger and longitudinal studies are needed, especially in underrepresented groups such as missense mutations, And this is what our natural history study that will be presented later today is aiming to do. So I would like to thank the team. I've mentioned them before, but like I said, this has been a collaborative effort, not just between researchers, doctors, and scientists, but between us and the family as well. So I would really like to thank all of the 125 families that joined us. Without your support and participation, none of this would be possible. So thank you very much.